హలో మేడం. అనురాధ మేడం.
హలో, ఒకసారి శ్రీకాంత్ కి మోహన్ సార్ ఫోన్ చేయి, రాకపోతే స్టార్ట్ చేసేద్దు కానీ. ఓకేనా?
ఇంట్లోనే ఉన్నా.
మాట్లాడు మేడం.
హలో
హలో మేడం,
చెప్పమ్మా.
స్టార్ట్ చేయమంటారా మేడం?
హలో రవి.
హలో మేడం,
స్టార్ట్ చేసేమ్మా.
ఓకే మేడం. గుడ్ మార్నింగ్. Today my topic is peri-operative care of patients with kidney diseases.
హలో
మేడం.
మీ మోడరేటర్ లేదా?
మేడం వాయిస్ కట్ అవుతుంది మేడం.
రాలేదా?
వీడియోనా మేడం?
జయరామ్ వచ్చాడా అని అడుగుతున్నా.
మోడరేటర్ రాలేదు మేడం.
ఓకే ఓకే ఓకే.
Introduction. Spectrum of renal patients. Renal dysfunction represents a spectrum of disease with potentially far-ranging consequences on surgical and anesthetic management due to not only the underlying disease process but also from the intervening medical and surgical therapies. Furthermore, optimization of the patient with renal dysfunction is to not only consider the pre-existing renal function but also the potential risk of acute kidney injury in the peri-operative setting. Pre-operative assessment. A careful history should have been taken initially from the patient before any examination or investigations occur. Patients with CKD may have complex and overlapping medical problems such as loss of renal function, diabetes, coronary artery disease, hypertension, anemia, dyslipidemia, poor nutritional status, neuropathy, and an overall decreased quality of life. Concept of preoperative diagnostics. Selective routine preoperative diagnostics are performed in patients with CKD. Avoid excess and unnecessary blood draw procedures preoperatively and during hospitalization in this generally anemic patient population. Avoid IV line placements and blood draw procedures in the non-dominant arm of a patient who will be starting dialysis in the near future. In this situation, the vasculature needs to be protected for the creation of an AVF or graft. Investigations. Urine analysis. Urine dipstick or analysis is useful to detect undiagnosed diabetes or UTI. It may also detect hematuria or abnormal proton loss, serum creatinine, blood urea nitrogen, and EGFR. This detects underlying renal deficiency and the possibility of developing AKI after major surgery. It may also influence the choice of drugs given during anesthesia. And EGFR should be calculated to not only ensure that correct dose adjustments are made for renally excreted medications, but also to help quantify perioperative risk. Acute kidney injury in the setting of CKD should prompt an evaluation to identify precipitating factors, and elective procedures should be postponed until resolution. Optimizing management for patients with known CKD or AKI. Measures include optimizing blood pressure and fluid balance, correcting acidosis or hyperkalemia. Drugs that are excreted solely via the kidney should be used cautiously and with appropriate dose adjustment. Review the drugs that are already taken with patients that may put them at risk of AKI. Those with anemia secondary to CKD should not be transfused preoperatively unless there is evidence for ongoing blood loss, as transfusion may precipitate fluid overload and hyperkalemia. Patients with CKD and conservative treatment should be rapidly assessed about the duration of CKD, level of renal dysfunction, and whether the elevation in blood urea nitrogen and creatinine is prerenal, intrarenal, postrenal, or a combination of these on a background of CKD. Patients who are euvolemic, responsive to diuretic therapy, and or have no significant electrolyte abnormalities or bleeding tendencies are uncomplicated cases and do not require dialysis before surgery. Patients with edema, congestive heart failure, or pulmonary congestion are those who are responsive to diuretic therapy require further cardiovascular evaluation. If the results of the cardiovascular evaluation are optimal, then fluid overload can be attributed to CKD. Combination diuretic therapy can help treat these patients to achieve euvolemia prior to surgery. Patients with CKD and may need dialysis. Patients with diabetes have a greater tendency of patients with diabetes have a greater tendency of having volume overload or CVD. Patients may develop diuretic resistance with progressive edema. Preoperative dialysis may be considered in these patients. If postoperative dialysis is imminent, the surgeon should be advised to place a temporary catheter intraoperatively. This avoids the use of femoral cannulation, which carries a high risk of infection. Permanent vascular access placement can then be arranged when the patient is more stable. Renal risk assessment and interventions. Further deterioration in renal function can be avoided by identifying and eliminating potential nephrotoxic agents. These include substitution or dosage adjustment for antibiotics, sedatives, and muscle relaxants. NSAIDs should be avoided. Electrolyte abnormalities must be identified and corrected perioperatively. Use of pethidine for postoperative pain control should be avoided because of accumulation of its metabolite norepinephrine, which causes seizures in CKD patients. Renal risk assessment and interventions in dialysis patients. CKD patients those who are already on dialysis, the following need to be determined: dialysis adequacy, pre-operative dialysis needs, post-operative dialysis timing, dosage requirements for all medications. Patients on hemodialysis usually require pre-operative dialysis within 24 hours before surgery to reduce the risk of volume overload, hyperkalemia, and excessive bleeding. Patients on peritoneal dialysis who are undergoing abdominal surgery should be switched to hemodialysis until wound healing is complete. Peritoneal dialysis should be continued for those undergoing non-abdominal surgery. In renal transplanted patients, drug-drug interactions such as cyclosporin or tacrolimus taken by these patients for immunosuppression are metabolized by cytochrome P450 system in the liver. Macrolides, diltiazem, statins, antifungals inhibit the P450 system and elevate the levels of cyclosporine or tacrolimus and can precipitate nephrotoxicity. Carbamazepine, barbiturate, theophylline induced P450 system reduce the levels of cyclosporine or tacrolimus and can precipitate rejection. Graft rejection. Drug levels must be monitored in this setting. IV cyclosporine or tacrolimus should be given at 1/3 the oral dose until the patient is able to tolerate oral medications. Surgical risk in CKD patients. Surgical risk depends on the type of surgery and whether the procedure is routine or performed on an emergency basis. The extent of renal impairment and the use of dialysis also affect outcome on subsequent morbidity. Cardiac arrhythmias and sepsis are the most common causes of perioperative morbidity and mortality. Surgical risk as related to CKD can be divided into following areas: need for surgery, specific surgical techniques, fluid shifts and blood loss, analgesic requirements, intravenous access, anesthetic techniques. Surgical risk, specific techniques and contrast media. Current recommendations to prevent contrast-induced nephropathy are adequate prehydration with IV crystallide, use of lower volumes of contrast, avoidance of other nephrotoxic medications, prevention of hypotension, use of adjuvants such as sodium bicarbonate or N-acetylcysteine. Laparoscopic surgery is associated with a reduction in renal perfusion. To preserve renal blood flow, recommended abdominal insufflation pressures are less than 15 mmHg. Laparoscopy can cause hypotension, which will further aggravate reductions in renal perfusion. To overcome these changes, adequate fluid replacement is recommended. Surgical risk, fluid balance. Maintenance of euvolemia and renal perfusion and assessing their adequacy in the perioperative period are the obvious goals. Features of hypovolemia can be masked by anesthesia and surgery. Intraoperative blood loss and fluid shifts during surgery can compound these problems. Invasive monitoring may improve the assessment of euvolemia and renal perfusion. Targets are mean arterial pressure greater than 65 to 70 mmHg or higher for the uncontrolled hypertension. Urine output should be greater than 0.5 ml per kg per hour. Central venous pressure should be greater than or equal to 10 to 15 mmHg. Surgical risk, fluid balance and resuscitation. Fluid resuscitation is typically with either crystalloids or colloids or blood products as indicated. The ideal recommended fluid is normal saline for patients with kidney dysfunction. Normal saline is hypertonic and hyperchloremic compared with plasma and volumes of plasma and volumes of greater than 30 ml per kg can lead to hyperchloremic metabolic acidosis and exacerbation of hyperkalemia. Overhydration and goal-directed therapy to supranormal values can have a negative effect on patient outcomes such as ileus, pulmonary edema, and prolonged hospital admission. Surgical risk, analgesic requirement. Opioids may accumulate in patients with CKD, placing them at higher risk of respiratory depression. NSAIDs are not recommended. Other options for moderate to severe postoperative pain include indwelling peripheral nerve catheters, long-lasting peripheral nerve blocks, or epidural catheters as applicable. Surgical risk, vascular access. Central line placement may be required or a peripherally inserted central catheter can be placed preoperatively for cases not associated with significant fluid losses or for cases requiring ongoing postoperative IV medical therapies. If future vascular access grafting is contemplated, IV line placement and blood draw should be avoided in patients non-dominant arm. Anesthetic techniques. Anesthetic techniques for surgery can be grouped into GA, neuroaxial anesthesia, peripheral nerve blockade, or sedation. The selected anesthetic technique will be determined by the patient's coexisting disease, surgical approach, and desired anesthetic goals. During induction, all commonly used anesthetic agents except ketamine decreases systemic vascular resistance, reduce both cardiac contractility and cardiac output, and attenuate the normal response to hypovolemia. The hemodynamically unstable patient is therefore at risk of cardiovascular collapse. The dose of induction agent should be carefully considered. Many patients at the risk of AKI will need a reduced dose. Prior to renal excretion, induction agents undergo redistribution and biotransformation into inactive products. However, in hypovolemia, there is a diversion of blood to essential organs and across the blood-brain barrier. Therefore, effects of induction agents may be exacerbated. Anesthetic techniques are isoflurane and desflurane are safer to use in CKD patients. Opioids, AKI prolongs the action of opioids as they are renally excreted. Lower doses are recommended in these patients. Muscle relaxants, Suxamethonium should be avoided as it increases potassium efflux from muscle cells and can lead to life-threatening hyperkalemia. It should be avoided in hyperkalemic patients. The administration of general anesthesia causes reduction in renal blood flow, resulting in impaired excretion of nephrotoxic drugs. Function of cholinesterase is impaired, resulting in prolonged muscle paralysis if neuromuscular blocking agents are used. Surgical risk versus bleeding. Uremia can cause platelet dysfunction that increase perioperative bleeding. To minimize uremic complications, patients with end-stage renal disease should undergo dialysis on the day before surgery. Bleeding time is the most sensitive indicator of the extent of platelet dysfunction. Higher bleeding time greater than 10 to 15 minutes are associated with higher risk of hemorrhage. Anti-platelet agents including aspirin and dipyramidal should not be given within 72 hours before surgery in patients with ESRD or uremic CKD. Bleeding correction. A small amount of heparin is used during hemodialysis with a residual anticoagulant effect lasting as long as 2.5 hours. Therefore, a waiting period of at least 12 hours after the last hemodialysis with heparin before an invasive surgical procedure is needed. Options for correcting elevated bleeding times in patients with renal failure are intensive dialysis, desmopressin 0.3 micrograms per kg IV 1 hour before the surgery, cryopressure 10 minutes over 30 minutes IV, transfusion of packed RBCs to raise the hematocrit to at least 30%. Anemia and hematocrit level in CKD patients. Patient develops anemia because of decreased renal production of erythropoietin. Increased intraoperative complications are observed in patients with ESRD and preoperative hematocrit levels ranging from 20 to 26%. Correcting severe or hemodynamically significant anemia avoid complications from perioperative blood loss as well as hemodilutional effects. Given these concerns, transfusion is necessary in certain circumstances. Anemia treatment in CKD patients. If the surgery is elective, EPO may be administered to raise the hematocrit to the upper acceptable value, that is 36%. Treatment should be initiated several weeks before surgery. Iron stores should be checked in all patients receiving erythropoietin. For maximum effectiveness of erythropoietin, iron deficiency should be treated. Evaluation of cardiac risk. Because of the high prevalence and rapid progression of the coronary artery disease in patients with kidney disease, cardiac evaluation must be done. 1/2 of all deaths before and after kidney transplantation are due to cardiac causes, with diabetes increasing the chance of atherosclerotic disease. Targeting cardiac testing to patients with risk factors increases the positive predictive value of an abnormal test that suggests the presence of underlying heart disease. Cardiac risk factors include age greater than 50 years, history of angina, diabetes mellitus, congestive heart failure, serum creatinine greater than 2 mg per deciliter, abnormal ECG. Stress testing, radionuclide scanning, and stress echo have been used to screen for coronary artery disease in patients with end-stage renal disease. Minor procedures do not require an extensive cardiac evaluation unless the preoperative ECG is abnormal. Cardiac revascularization is typically reserved for use in patients whose cardiac risk is high. Perioperative AKI prevention. Measures to prevent AKI are optimization and management of comorbidities and hemodynamic derangements have been shown to improve renal function. The patient's intravascular volume should be adequately restored. If necessary, an arterial line inserted and other invasive monitoring techniques considered. Intraoperative renal protection. The aim of intraoperative management in those at risk of AKI is to maintain adequate renal perfusion. The following measures may allow optimal intraoperative care: appropriate intravascular volume replacement, avoidance of nephrotoxic drugs, urinary catheter aiming for a urine output greater than 0.5 ml per kg per hour, maintenance of suitable mean arterial pressure for patient and operation, monitoring of central venous pressure, monitoring of cardiac output. Intraoperative renal protection. Vasopressors. There is no evidence supporting the use of renal dose dopamine. Anticipation of anesthetic and surgically induced hemodynamic perturbation, both intra and post-operatively. Intraoperatively, the neurohormonal response to surgery causes sympathetic response, releasing vasopressin, aldosterone, and cortisol in the fight or flight response. One of the aims of this is to aid salt and water retention, protecting the renal vasculature. Anesthetic agents, ACE inhibitors, and NSAIDs will alter this protective response. Post-operative care. Post-operatively, patients may remain at risk of AKI due to relative hypotension caused by ongoing third space fluid loss, pharmacological causes such as NSAIDs and ACE inhibitors or ARBs, and residual effects of anesthesia. Epidural anesthesia has been cited as being particular culprit by causing hypotension secondary to sympathetic blockade. The risk of AKI will be exaggerated if there is inadequate intraoperative fluid replacement. Post-operative fluid therapy is of utmost importance. This is guided by clinical examination, monitoring of urine output, and monitoring of renal function and electrolytes. Those with significant metabolic disturbance, example acidosis, hyperkalemia, uremia, or fluid overload, not responsive to simple measures, may need renal replacement therapy in an appropriate setting. What to do if AKI ruled in? With good initial assessment and simple measures, including fluid management and avoidance of nephrotoxic drugs, it is preventable. AKI is preventable. Patients who develop AKI and have complications such as hyperkalemia, electrolyte imbalance, acidosis, or volume overload are likely to die unless renal replacement therapy is provided. If the AKI is confirmed, multiple interventions can be initiated. An abbreviated list include evaluate treatable causes of AKI such as rhabdomyolysis, obstruction, volume depletion, glomerulonephritis, sepsis, acute interstitial nephritis, vascular events such as arterial dissection, atheroembolic disease, thrombocytopenic purpura. Optimize hemodynamics and consider objectively assessing cardiac output. Example, pulmonary artery catheter, echocardiography, non-invasive cardiac output monitoring via arterial line. Consider initiating goal-directed therapy with an emphasis on conservative late fluid management after the initial resuscitation. Minimize exposure or discontinue when possible all nephrotoxic drugs, example NSAIDs, aminoglycosides, amphotericin, radiocontact material. If the patient is fluid overload and resistant to diuretics, then consider ultrafiltration. Conclusion. Patients with CKD or AKI who present for surgery often have complex medical problems. Pre-operative evaluation should strive to identify and correct any modifiable risks. Communication between the primary care team, nephrologist, surgeon, and anesthesiologist should ensure timely and appropriate investigation. Despite optimization, patients with CKD or AKI are at significantly higher risk of morbidity and mortality during the perioperative period. These risks need to be communicated to the patient or caregiver so that informed medical decisions can be made. Perioperative goals for euvolemia, maintenance of renal perfusion, and avoidance of nephrotoxins may require modification in the usual surgical or anesthetic care. Despite intense research into the perioperative renal protection, many successful therapies in animal models have not achieved success in human population. Phenoldiazepam, a prophylactic therapy in patients with CKD undergoing high-risk surgery, or for those patients at high risk of AKI may be beneficial. Madam?
Thank you, Ravi. Any questions from audience? Dr. Rani Madam, Dr. Ramana Prasad sir, Dr. Vinay Kulkarni sir.
Hello, good morning.
Good morning, sir.
It's an excellent presentation, Dr. Ravi Kumar.
Thank
You
you,
have covered really all the points very well, and it's been a very good presentation. It was good to refresh all the points. All the issues have been covered actually. So, comment which I wanted to make was, I mean, yes, all pre-operative optimization and everything is there, but like given a situation where you have to see a patient and take him for a short surgery or a short or intermediate surgery, the points which I would look at is a quick look at the potassium and urine output, and if it's an elective or semi-elective or semi-urgent case, even if the potassium is something around 5+, we would really like to kind of confirm that he's got a good urine output and makes kind of has got an opportunity to reduce potassium, because any surgery will have catabolism and rise in potassium. So that can be very dangerous. A small, trivial, insignificant surgery can also become a disaster. So it is very important to be extremely careful in the preoperative assessment and declaration that yes, this case can be taken up for surgery safely or not. So I think all those points have been very well covered. Another point is sometimes, like in situations, I would like to look at the ABG. I'm not sure whether it was covered in the talk or not, but a preoperative ABG can, because many times patients look quite well, but if you look at the ABG, they'll be having significant metabolic acidosis and base deficit. So that can really help us make a judgment as to who can be where we can plan dialysis or not. The other thing is, most surgeries obviously will have to be planned in a situation in the center where dialysis facilities are available. Nowadays, most hospitals do have dialysis, but smaller units, smaller nursing homes do not have these facilities. So obviously these patients have to be transferred to a situation where all these things can be taken care of.
Thank
Yeah,
you.
that's all.
Thank you.
Thank you, sir.
Hello, good morning.
Good morning, sir.
To the DNB students, what is the length of kidney in ultrasonogram? And what is the significance of spot urine sodium test? Shall I tell?
Yes, sir.
The length of the kidney is 10 to 14 centimeters. Urine spot sodium, usually if it is less than 20, it indicates hypovolemia. If it is more than 40, it indicates SIADH, syndrome of inappropriate ADH syndrome.
Okay, sir.
Okay, sir.
Any questions from Rani madam and Hari Krishna, Lavanya, Sai Sujan, Gayatri Devi?
Good presentation, Ravi. Thank you.
Good morning, madam. Thank you, madam.
We can close the session, ma'am. Thank you, Dr. Ravi, for good presentation
Thank you,
and
madam.
nice topic.
Thank you.
Thank you to all. Thank you.
Thank you.
Thank you, sir. Omkar, any questions?
No, madam. No, madam.
Okay, thank you.